PRADHAN. I'm sorry I can't pronounce your first name, it's a little tongue twister. You'll be speaking a punch, a leak, a hospital trip, endophthalmitis following blunt injury.
Good afternoon, judges. Thank you, scientific committee, for allowing me to present here. So, I will present one case of endophthalmitis that's following blunt injury. So, it was a 44-year-old male who had presented to us with sudden diminution of vision in the right eye for 3 days following blunt trauma with fist from his friend's hand actually. So diagnosed also as endogenous endophthalmitis, and AC anterior chamber was given, and intravitreal vancomycin and ceftazidime was given already 1 dose. But there was no history of any other systemic problem and no history of fever. So when the patient came to us, he told he had a history of radial keratotomy that was done 27 years before. Patient presented with PL positive vision. There was presence of 1 millimeter of hypopyon, and vitreous exudates was there in ultrasound B scan. So this ultrasound B scan shows this plenty of vitreous exudates, and retina was attached, but there was thickened choroid. So the choroid was 2.08 millimeter. So, is it endogenous endophthalmitis? So, before coming to the conclusion, so there are two things to be pointed out. This one is spontaneous corneal perforation, that is rare, but can be a long-term complications after radial keratotomy. And as the patient had a history of trauma, and the keratotomy area can open up momentarily and can be the source of infection. So, so there is the history of trauma, this is one point. Another one is history of radial keratotomy. So these 2 points was against the endogenous endophthalmitis, and there was no other systemic problem or any fever we could find. So vitrectomy was done, and the lensectomy was done as the exudates was present at the anterior capsule and the posterior capsules. And anterior capsular rim was kept intact during surgery, keeping in mind that we can put secondary IOL later. So this was subsequent visit fundus photo of the right eye, the view become clear. So after postoperative period, we have given intravitreal antibiotic injections also. So the gram-positive cocci was cultured, Streptococcus viridans was grown in culture, and multiple intravitreal antibiotic like vancomycin and ceftazidime was given after that. So he was also started on topical antibiotic and oral ciprofloxacin and IV antibiotic also. So this is 8 months after the primary surgery. The vision was improved with +10. The vision was 6.9. So we planned for the secondary IOL implantation. So base corrected visual acuity was improved to 6.9. And we put the secondary IOL at the sulcus 3-piece IOL after 8 months after the primary surgery. So coming to the discussion, in case of radial keratotomy, the depth of the corneal incision can be like 80 to 90% of the corneal thickness. And for endophthalmitis to occur, the organism must traverse the descending membrane to enter the anterior chamber. So for the trivial trauma, sometime can, as because this already the depth of incision 80 to 90%. So sometimes the trivial trauma can cause the breach of the descending membrane and can cause endophthalmitis. So it may occur without the history of recognized perforation. So the patient may have an unrecognized perforation after blunt trauma, or could have been subsequently developed a microperforation from the necrosis at the base of the wound. The microperforation might not have clinically evident, especially if stromal edema later sealed the site. So for my take-home messages from this case is with incisional refractive surgery, it is important to be aware that an occult perforation may occur at any time with trivial injury. Though blunt trauma rarely causes endophthalmitis, it can happen in post-radial keratotomy cases. And when vitrectomy is planned in post-radial keratotomy eyes, we should be very cautious and to keep infusion pressure low to prevent the opening of the corneal incision areas. Thank you. Thank you.
So when you did the vitrectomy, that time also you could not find any break in the radial keratotomy incision?
No, there was no leakage from that side. We kept
no,
the.
Did you, press the cornea or try to see that is there any leak somewhere? Because
Yeah, we tried and
you could not find.
but we couldn't find any tear there.
Yeah, because
So-
one of the case, I think we did the suturing as well. Like
Okay.
when the vitrectomy, we do know if there
Yeah.
is a leak, sometimes it may give way, like the sir was telling, no?
Yeah,
So better to recognize and suture until it heals,
okay.
I feel.
I think they have said it very rightly, especially in RK cases.
Yeah.
And you should not worry in case even if the RK is opening up, all you need to do is suturing.
Yeah.
As madam said, that suturing is very important.
Yeah.
And of course, that's a very valid point what Dr. Ashish has mentioned about the break.
Otherwise, it's a good, you've managed it very well, and especially you've preserved the capsule so that you can put the IOL later on.
But it's a good case you have presented, a good case.
And
Yeah,
it's
I
something
searched
to
a
ponder.
few literature, so they were showing sometime the stromal edema can close the
Yes.
momentarily it can open and this infection can go inside, but after that it was closed, maybe self-sealing
Right.
it was.
I hope all of you are aware what is RK, the radial keratotomy,
Yeah.
which was being done with a diamond knife to flatten the curvature of the cornea to reduce the myopia.